Can we continue now with our next lecture?
Thank you.
Dr. Nikola Lazovski, assisted primary patency rate after stenting in GSV bypass.
Ladies and gentlemen, today's presentation is about assisted primary patency rate after stenting in great saphenous vein bypass. We all know how the peripheral artery disease is treated. Is conservative treatment, endovascular treatment, and at the end surgery. According to the huge studies, Basel 1 and 2 and BEC CLI, we know that when endovascular treatment is failed, then we are going to the great saphenous vein bypass if there is a good great saphenous vein. But what to do when even a vein graft fails? According to nowadays evidence, all we have to do is surgical reconstruction of the sixth segment of the great saphenous vein bypass. But is there any endovascular options? In the literature, we cannot find any kind of data for endovascular treatment of this kind of lesions, especially in the lesions of in the groin area. There are 3 cases which we treated endovascularly. The first one is a Rutherford 3 class patient with previous SFA and popliteal artery stenting, and after this bypass with great saphenous vein, and now he has claudications and ABI 0.7. This is CT angio, but in the sake of time, I'm going further. This is the 3D reconstruction. If you can see here, there is an osteal lesion of the great saphenous vein bypass. Oh, this is the other projection. And we tried to manage it in endovascular way with the crossover maneuver. We came to the anastomosis and put a 014 wire and did a ballooning, but after ballooning there was a recoil, and then we decided to put Promus Premier below the knee stent. This is an everolimus stent with great result. It's a drug-eluting stent. The second patient is Rutherford 4 class, previously operated with aorto bifemoral bypass. And after this, because of the closure of the right limb, he was managed with the great saphenous vein bypass with the crossover until P1 on the other leg. And now he's with monophasic Doppler signals on the right foot with ABI 0.5. On the CT angio, we found this kind of lesion. Also osteal stenosis of the great saphenous vein bypass. You can see in the other projection, maybe better here. And we managed to do it from below. There was also a stenosis of the left limb of the previous bypass. Then we put an epic stent on this territory just to improve the inflow. And after this, we went to the anastomosis of the vein, then put 014 guide wire, do the ballooning, 3.0 I think Sterling, several times, long ballooning, but there was a recoil again. Then we again decided to put Promus Premier below the knee stent with excellent result. And the third patient, it was a Rutherford 5 class patient with several surgical procedures previously, and at the end he ended with a crossover PTFE which was infected in the right groin, and then we managed to do the partial removal of the graft and put a vein bypass in this territory only. The infection resolved and the wound closed excellent, and after 1 year he came with 0.4 ABI with monophasic signals with the ulcers on the foot. So this is his CT angio, and this is the 3D reconstruction. I don't know if you can see well. Here is approximately 1 centimeter above the distal anastomosis is the severe stenosis. Here you can see better. Here is the severe stenosis. And we managed to do it through the previous crossover bypass. We also did here Kayeri ballooning, but there was no effect with ballooning. Recoil again, and then we finished again with the Promos Premier below the knee stent with excellent result. After this, all three patients were followed up in 1 month, 3 months, and 6 months. They have excellent clinical improvement, and they have improvement of ABI indexes, which was stable during all the time of the follow-up. And there was another patient. It was 4th patient, but from the moment of the CT angio until he came on the table for treatment, his bypass was occluded, and we couldn't manage to do anything with him. And all of these patients has a problem in the groin region. According to the literature, there was only one study that was dealing with this problem, but this Italian study was dealing with the problem with the great saphenous vein bypass in the distal anastomosis, and I will show you this later. This study is on around 20 patients with a good result endovascularly, but we couldn't manage to find anything in the literature for these groin lesions. We want to believe that the scar tissue is the problem in this region for the stenosis and subocclusions of the great saphenous vein bypasses. That's why we proceed with using this kind of the endovascular treatment. Because scar tissue, I believe that the scar tissue didn't allow us to open with ballooning to open the sick part of the vein. That's why we used Promos Premier, because it has excellent radial force, and in some way it is a drug-eluting stent with everolimus, and it has a topic. Activation of rapamycin locally in the region of the stenosis, and we all know what rapamycin function is. There are several studies that show us that rapamycin is very well known for stopping the scar tissue and its ingrowth. In another study, we found that, but this is a small study and is on dogs, we found that arterialization of the vein after 6 months after implantation is much more permeable than initial phase of the implantation. And in our thoughts, this could be a good endovascular solution, but we need more evidence for this kind of treatment. Thank you for your attention.